general practice. I'm a family physician. And actually, I'm wearing multiple hats as I have been involved with biomedical research and clinical trials for several years. And I'm now the co-founder of Lumos. But about this, we're going to talk in a little bit. So from this experience in the biomedical research, I have come to observe different problems. And I want you to imagine these problems this morning. Imagine how difficult it is for clinicians and researchers to collect data from different sources, from rural and isolated areas, from contexts with limited financial and technical resources, and from the developing countries. Consider how demanding it is to coordinate all the researchers and to try to encourage them to participate more, to provide more follow-up data, and to improve the quality of the data that they provide to in the research. Think how challenging it is to having to deal with multiple healthcare systems, different administrative problems and issues while trying to provide the very best for your own patient. Finally, consider that the current methods are not very good. There are in many parts of the world, the use of a paper questionnaire is still a reality. There are pieces of software that are not friendly, are not intuitive, and they are not standardized. So out of this experience, we have come to ask ourselves, how might we make research multi-ethnic? How might we make the research multi-ethnic regardless of the area of origin and of the disease? Because research should not be only about white males coming from urban centers. How might we enable the coordination and the engagement of the researchers coming from areas all over the world? And finally, how might we involve patients in the research process and help them with their quest to raise awareness about their problems and about their conditions? So, as I said in my introduction, I have collaborating in the development of an online platform. The name is Lumos, which is a platform specific for biomedical research studies that enables a holistic approach for the development and coordination of projects and the collaboration among the stakeholders. Now, with Lumos, researchers, healthcare professionals, the academia, research organizations can develop questionnaires with multiple variables and multiple and customizable fields. For instance, here we are developing a questionnaire with the Fagerstrom test for nicotine dependence. And then they can set up studies with a specific methodology. For instance, here we are setting up a randomized controlled trial with 2 groups and 2 rounds of follow-up. Finally, there are also tools that enable the researchers to manage the subjects that participate in multiple studies in a flexible way. Now, this was the project that I was working. I have been working since 3 years now, and you may ask yourselves, how might we take patients and really involve them in this process? There is a growing body of evidence that argues in favor of the patient's ability to report on their symptoms, on pain, side effects, and daily functioning. The patients are increasingly becoming skilled at searching for healthcare information, making their own decisions, and collaborating with others. The advances in connectivity and the wide availability of data pushes the healthcare towards a more patient-centered model, and the patient and public involvement is bound to change even the most rigorously scientific areas such as the biomedical research. So these were the patients, but what about the caregivers? Let me introduce to you Rita Lydia Stara. She's a mother of 3 2 of whom have been diagnosed with type 1 diabetes mellitus. Rita has focused her life on improving the quality of the life of diabetics, and she's now the chair of 2 federations in Italy, one regional and the national one. Now, Rita, the Federation of Diabetics, the regional administration, and the regional healthcare service of Emilia-Romagna, this is a small region in the northern part of Italy, have this project that aimed at investigating the behavior, the necessities, and expectations of diabetics that receive insulin and use blood glucose self-monitoring devices. A questionnaire was already developed and approved by the local authorities, and the federation and the regional administration approached us, and they wanted to see whether they could use our platform for their purpose, for their survey. So we found that this was a very good opportunity for us to actually work with patient associations and try to transform our platform, which was initially aimed to healthcare providers, to researchers, to transform it into an open public survey tool and offer new characteristics that would help patients collaborate and participate in research themselves. So we added features such as a control of the number of submissions, the automatically generated QR codes, and the sharing of the survey to social networks. And we simplified the supervision of the whole process with reports. So this was the public campaign that accompanied the survey. As you can see, there was an automatically generated QR code down there, and patients that were in the waiting room of their family physicians could take their device, scan the QR code, and they had the questionnaire ready on their device, and they could fill in the questions right away. This is the tailored installation of the platform, and if we go back in the backstage, we can see the addition of the QR code, the sharing to the platforms, the several disclaimers, the informed consent that was added according to the wishes of the regional administration and of the Federation of Diabetics. Finally, we tried to simplify the report making so that the coordinators of the researchers of this research were able actually to monitor the process and to make actually snapshots of their research and save them for future reference. Now, in the period of 3 months, we gathered 282 paper questionnaires and 178 web questionnaires. These are some very preliminary results of the sample that we have. And what is very striking is that the ratio of the caregivers, of the participating caregivers, was significantly higher in the online version of the questionnaire. We had 35.4% of caregivers compared to 8.9% in the paper and pencil version of the questionnaire. Moreover, the mean age of the adults was significantly lower in the online version of the questionnaire compared to the paper and pencil one. And these participants, the online participants, completed actually a higher percentage of items in the questionnaire compared to those who just filled in the paper and pencil questionnaire. Now, there was also an inverse correlation between the items that were completed and the age, and we found that the effect size of this correlation was higher in the paper questionnaire compared to the online version of the questionnaire. We didn't find any relevant differences with regards with the time of the completion of the questionnaire. both patients and caregivers, the median of the time was approximately 12 minutes. And finally, almost half of our sample stated their email address voluntarily, although the questionnaire was supposed to be an anonymous one. So out from this experience, first of all, we came to compare the two methods. And we saw that the adherence in the online version of the questionnaire was higher compared to the paper one. There was the real-time checking and the decrease in missing data that increased actually the integrity and the data quality. Also, we should consider that there was a decrease also, there should be a decrease in the social desirability bias for the online version of the questionnaire. And finally, we have the opportunity to have access to some groups, such as the shift workers, the homebounds, or the patients that lived in the rural areas. Now, imagine the potential of having this information directly from patients, of having reports from of the patient's health without interpretation by others. Imagine the potential to have information on observable, such as observable outcomes, such as wheezing, coughing, etc., and non-observable ones, such as pain or the depression symptoms, that come directly from the patient. And imagine how the value of the information that is related to the disease burden and to the treatment efficacy. Now, out of this experience, we believe that by providing tools to patient associations in their bottom-up approach of carrying out research projects, we think that their advocacy role will be enhanced and their members will be empowered to participate more actively. And this way, we believe that patients will be repositioned at the center of healthcare and their involvement in the decision-making will become the cornerstone of the new era of medicine and research. Thank you.